To open the next session, please welcome Dr. Jose Jasper Andal, molecular pathologist and quality assurance officer at St. Luke's Medical Center, Philippines.
Good evening, ladies and gentlemen. The next lecture is entitled New Strategies in Molecular Pathology, Liquid Biopsy, Microbiome, and Digital Pathology. Our distinguished speaker is Dr. Richie Chuan Soong. He is the founder and chief executive officer of Pacific Private Limited. He is the founder of the Center for Translational Research and Diagnostics and associate professor at the National University of Singapore. He has published over 160 articles and patents with more than 6,000 citations and has been awarded more than $20 million in academic and industry grants as the primary investigator. He has been invited to give talks worldwide on medical genomics, liquid biopsies, digital pathology, molecular pharmacology, and precision healthcare. Ladies and gentlemen, please welcome Dr. Richie Chuan Soong.
Good evening. My name is Richie Soong, and I'm here to talk to you today about new strategies in molecular pathology, namely liquid biopsy, microbiome, and digital pathology. Here are my disclosures, most specifically that I'm the founder, director, shareholder of a Pacific group of companies. What I want to start with today is to convey to you that we are winning the war, and we're winning the war through adopting and developing advances. Here's the mortality rates you can see of lung cancer patients from 2001 to 2016. And you can see the mortality rates are dropping quite significantly. What they have concluded is our analysis suggests that a reduction in incidence along with treatment advances, particularly approvals for and use of targeted therapies, is likely to explain the reduction in the mortality observed during this period. And we haven't even got into the period of immunotherapy yet. I usually put this slide up as it describes all the advances that have happened over the years from the 1800s up to 2020, from morphology and chemistry up to the microbiome, from microscopy up to artificial intelligence, from surgery up to microenvironment modulation. And they're not just advances just for the sake of it. With each of these advances, you can see an improvement in survival, from cytotoxics to molecular targeted drugs and precision medicine to immunotherapy, each adding on top of each other to improve human health. But for today's talk, I'm focusing on three of these advances: liquid biopsy, digital pathology, and microbiome. So for liquid biopsies are the sampling and analysis of bodily fluids as a means to assess the characteristics of often distant tissues of interest. This could include detecting circulating tumor cells, cell-free DNA, extracellular vesicles, and the sources of these can be blood, bone marrow, CSF, sputum, stool, washings, and urine. Essentially what we're doing is, instead of sampling the tumor, we are able to sample molecular changes in the bloodstream or in other sources, either derived from necroptosis, apoptosis, or secretion. The value proposition is probably easy to see. Instead of a tissue biopsy, which is an extremely invasive procedure, it promises that we can use liquid biopsies to determine the same molecular changes and determine the same prediction possibilities. Liquid biopsies are less invasive, but they're technically challenged. So new opportunities, they open up quite a number of new opportunities. That is testing where tissue biopsy is not possible, testing where DNA quality from tissue biopsy is poor, testing for DNA response, for drug response and resistance, and in the monitoring of disease progression. And as you look at the evolution, you can see that most of the action has been happening in the last decade. And that's mainly because the technology had to be developed up to that point. We've got to the point now where cancer blood cell cytometry, such as the cell search, has been approved. Now we've had single genes, cell-free DNA being approved for treatment selection. And most recently, multi-genes cell-free DNA has been approved for treatment selection. And in the meantime, we've had controversy, and we've also had emerging results in serial cell-free DNA for treatment selection, and cell-free DNA being shown to be valid possibly for early cancer detection. I'll go over some of these examples. Here's an example of how of single-cell cell-free DNA being useful for treatment selection. They've proven that it's the cell-free DNA status is reproducible, it matches tumor status, and it provides similar outcomes. The tumor here, plasma here, between cell-free DNA and tumor EGFR status. The results for multi-marker cell-free DNA are very similar, but instead of just one gene, you're talking about many genes, 20s or 70s or hundreds. They've shown that it can actually detect more guideline recommended biomarkers than tissue. And they've also shown that results from such cell-free DNA tests are actually leading to response benefits in patients, regardless of which type they are. There are very many diverse types being detected. They're also starting to show that serial cell-free DNA monitoring is useful for treatment selection. So not just one single time point, but multiple time points can give you a different story. And they're showing that people with a response have a drop in cell-free DNA, whereas those that do not have a response have an increase. And interestingly, what they're showing is that the time to detecting recurrence is much faster with cell-free DNA than, for example, PET-CT and RECIST criteria. And they've also shown that progression-free survival is predictable by the drop, such as if you have a high drop, you have a much better prognosis than those with a low drop. Here's an example from our own laboratory and clinic. 77-year-old man with lung cancer, started in February 2004. A tissue EGFR test was ordered and EGFR was detected, EGFR mutation was detected. Therefore, the patient was provided lotinib, had recurrence, then progressed was provided carboplatin, pemetrexed, had another progression. And then from that point, a plasma liquid biopsy test was ordered and the C790 mutation was detected, and therefore osimertinib was provided. Now, if we had been able to have liquid biopsy monitoring, we went back and tested the samples that we've been obtaining from this patient. And lo and behold, look at this. You can imagine that, you can see that detecting early and monitoring early could have allowed us to detect T790 resistance early. And also, very importantly, it actually can help to identify that you're giving the right treatment. So you can see the big drop in T790 after the provision of osimertinib. They've taken this further recently, and they're trying to prove that cell-free DNA can be used for early cancer detection. And for this, this is one of the largest studies to prove this point. More than 15,000 participants using a wide variety of methods to try and find the signatures that can be used to both detect early cancer and also identify what sort of cancer it is. Don't forget, it's often in the blood that you're detecting. There's a number of elaborate study designs, but I'll shoot straight to the results that were reported this year at ASCO GI, where they reported that there was 91% accuracy in the training set and 89% in the validation set, with stage 4 having a much better accuracy than stage 1, but still nevertheless stage 1 and 2 were very high in accuracy. Very promising results suggesting that in the future, we may be able to detect cancer early through liquid biopsies. But before we get excited, there has to be a warning for caution and expertise is needed. Many of you may be familiar with the fraudulent claims from Theranos, where Elizabeth Holmes made claims that they could detect all sorts of things with a single drop of blood. She was valued up to about $9 billion, but in the end, they found that the claims were false, and basically the company is undergoing bankruptcy at this point. The other point to be wary of is that there are numerous studies have highlighted there is a lack of concordance between cell-free DNA assays between different suppliers. So for example, you see between 4 different groups a range of sensitivity between 38 to 89%, predictive value of up to 36 to 80%, and the conclusion was that about 68% resulted from technical discordance between the methods. Digital pathology is essentially the computerization of pathology processes. And there's 4 areas of value that digital pathology is showing some promise in. That's in the image and data management, which is essentially the computerized filing of images and data. This helps to reduce manual risks, it provides faster retrieval of images, better image preservation, and a smaller archive footprint. Another application is telepathology, which is essentially the sharing of images and data through digital media, which is enabling remote access and enhanced multidisciplinary collaboration. Digital image analysis is the assessment of images by the computer, which allows for the reduction of menial routines, lower inter-observer variability, after-hours processing, and new features and insights not available to the human eye and mind. And this is followed up with more sophisticated multi-parameter integration analysis, integrating clinical, image, and molecular information, which again is providing us new features and insights that may help to unlock things that have so far been unable to be solved. The evolution of digital pathology, again, has taken a long time to evolve from 1590, the first microscope invented, till the technology is available nowadays for such advancements. One thing to notice, as you probably can see, is that it's taking FDA some time to warm up to digital pathology, but they are starting to warm up. For example, they announced in 2011 it should be considered a class 3 device. Then they announced a trial to compare digital pathology to glass slides, eventually leading to the approval in 2017 of the whole slide imaging system. At the same time, CE-IVD approval has been made for digital pathology of immunohistochemical slides and artificial intelligence for diabetic retinopathy. And in the works right now are things such as analysis of H&E for new biomarkers, multi-marker digital slide analysis, and multi-parameter digital pathology, which I'll go over some of the examples. The promise of digital pathology is probably very obvious to many people. So you have automatic scanning, assisted review, file management, image sharing, and conference, which allows for reduced manual risks, faster retrieval of images, better image preservation, and smaller archive footprint compared to the conventional methods, which are extremely manual and individual, and you're having problems with space and fading of slides and images. Telepathology is also probably a very obvious concept, whereby now through the internet, we are able to connect tertiary hospitals, research institutions, pharmaceutical companies to the hospitals in the provinces, rural laboratories, sample collection. And all this adds up to enhancing access to places that have not had the quality of service before or ability to have service before. And it's also enhancing collaboration between many different diverse opinions and different experiences. One is not more so shown than during the pandemic time, this report just this month from Memorial Sloan Kettering, where they showed that digital pathology, telepathology was able to allow operations to go on during COVID time, where the pathologist would stay away from the hospital and still be able to proceed. And also they were also able to conduct education through providing these images to the fellow to report to the pathologist. Some of the things that they have developed in the pipeline is, for example, a H&E score, just computerized H&E score that calculates diversity. And this is shown to be able to be used to identify lung adenocarcinoma and lung squamous carcinoma of high risk versus low risk, and have a survival difference in many training and a validation series. They've also applied digital pathology to analyzing immunohistochemical stains. The immunoscore is probably the most famous of them all, where they are characterizing the density of CD3 and CD8 in both the tumor core and the invasive margin, identifying a score based on the percentiles, and showing things like that individuals with a high immunoscore are able to benefit from 6 months FOLFOX, whereas those with a low immunoscore have no benefit from 6 months FOLFOX. And that goes even further now. Instead of just bright field IHC, we are getting to the point where we are able to analyze 7 different markers at once to really put up a understanding of a single cell phenotype such as CD8, granzyme B, PDL1, Ki67, and understand how these cell phenotypes may be able to provide new insights to survival and drug targets and so forth. And groups like TracerX are taking it one step further by applying artificial intelligence, where they are able to actually use these artificial intelligence to identify those that have red hills, so to speak, where there's high local infiltration of immune cells compared to immune desiccated islets. So the microbiome is probably the last, is the most interesting, not last but not least. The microbiota includes bacteria, viruses, fungi, and single-celled archaea. There are actually more microbiota cells in the human body than our body, about 3.8 times 10 to the 3 bacteria. But most importantly, the microbiome is increasingly being linked to many health conditions such as obesity, cancer, lung disease, heart disease, and so forth. And then interestingly, everybody has got a unique gut microbiome. So we've tried the epigenome, the genome, epigenome, proteome, metabolome, transcriptome. This presents itself as a very promising frontier for understanding and identifying new biomarkers and therapeutics. Here's the group, here's the microbes that you're probably familiar with, such as prions, COVID, I'm sure everybody's familiar with that, TB, HIV, in cancer, HTLV, hepatitis B virus, hepatitis C virus, H. pylori, human papillomavirus. But interestingly, there are only about 4 microbes implicated in cancer, but when you go to the NCBI database, there are over 1,000 microbes, which means to say that I think there's much more to be discovered and much more to benefit human health. The evolution of microbiome health is a little bit more gray, more research than approvals. Vaccines probably been the last real approval in terms of microbiome health. But there's a lot of exciting work linking stress and gut microbes, starting of a human microbiome project, randomized trials on fecal microbiota transplantation, and showing that the discovery that microbes affect cancer therapy response, and developing cancer diagnosis through blood microbes, which I'll go over in the next following slides. So FMT, fetal microbiota transplantation, is probably one of the most interesting proofs that the microbiome is playing an important role in human health. It's the process of transferring fetal microbes from a healthy individual to a diseased individual. It's been used for applications such as Clostridium difficile infection, IBD, obesity, and the list goes on, including melanoma. Strangely, being able to replace fecal microbes, it seems to have an effect on melanoma. And they've shown this in FNT for recurrent Clostridium difficile infection, where infusion of donor feces was able to cure a much larger group than vancomycin alone. And this is related to changing the diversity of the bacteria involved in the donor after infusion of donor feces. Another great interesting line of work that our microbiome is unlocking is the relationship between the gut microbes and the brain. And this has been studied on both mice and human, and a lot of the findings are really interesting and exciting. Dysbiosis in the gut has been associated with anxiety, mood disorders, autism, depression, abnormal behavior, cognitive deficit, schizophrenia, and Alzheimer's and Parkinson's even. Here's one of the examples where using BR mice, they're using this to study how the influence of the gut microbes on autism spectrum disorder. They've identified significant differences in microbiota metabolism profiles, and that if you transplant the gut microbiota into germ-free mice, they developed autistic type hallmark behaviors, and which can actually be reversed if you change the balance in microbiota and chemicals. And at the same time, the NIH Human Microbiome Project has been ongoing, where they're characterizing microbiomes in many different areas of the human body and trying to correlate them with phenotype, and then further on trying to follow their dynamics over time with many different types of platforms. And without going into it too much, they've shown the diversity of the human microbiome. They've shown perturbation of microbes related to IBD. They've characterized differences in microbes between insulin-resistant, insulin-sensitive diabetes, and they've identified vaginal bacteria that are related to preterm birth. Probably the most interesting for the cancer audience is that the microbiome has been linked to anti-PD-L1 and anti-PD-1 efficacy in numerous studies now, and also demonstrated in mice where they have taken the microbiome from responsive and non-responsive donors and shown that Non-responsive donors have larger tumor size and reduced immune phenotypes, suggesting or supporting the role of the gut microbiome in immunotherapy response. And lastly, most recently, the studies on the Cancer Genome Atlas have started to identify microbiome signatures which can just differentiate tumor and normal tissue. And when these are applied to the blood, they can actually help to identify stage 1 to 2C cancers. So maybe possibly also, such as liquid biopsies, we can be using microbiota to identify cancer early. So in summary, liquid biopsies have been approved for selected multigene, at the stage where they've been approved for selected multigene cell-free DNA treatment selection. There are results emerging on serial monitoring and early detection. We need to be diligent and rely on expertise because there's a significant scope for inaccuracy and overclaim in this field. Digital pathology has been approved for selected digital H&E and HC scoring, immunohistochemical scoring. There are results emerging on multi-marker and multi-parameter approaches. However, there's a big problem in the field in that we are still trying to work out how to integrate this as an aid to conventional pathology and what is the cost model for going digital. The microbiome is one of the most promising areas for identifying new links to unsolved health conditions. Obviously, it's already been approved for many diagnostics, treatments, and vaccines. But probably the main problem is creating awareness of all the great possibilities in microbiome health, and especially all the science that's required to understanding the delicate ecosystem. So in conclusion, I would like to highlight that we are winning the cancer challenge through scientific and medical advances, and developing and adopting advances in liquid biopsies, digital pathology, and microbiome health promise further gains. So I'd like to finish by thanking the staff that have helped me compile this presentation, and I'd like to thank the staff in Pacific, working in Singapore, Philippines, and India, and I'd like to thank the audience for their keen attention. Thank you very much.
Thank you, Dr. Soong, for giving us those interesting developments in the era of molecular pathology. So for some questions from the audience, there's one here asking if, do you think comprehensive genomic profiling will become more affordable in the future?
Well, the answer is it should be yes. I think with everything, computers, cars, everything, after a while they become part of routine, and there's enough critical mass and there's enough throughput. I think it will become more affordable. Yeah, I think it really is a matter of working together and forming that critical mass to allow that throughput.
Yeah, I think it's more important in some resource-limited areas where it has to be of a certain price point to reach more of the masses. Another question here is, do we expect to see a loss of sensitivity in doing liquid biopsies for patients with early-stage cancers where the tumor burden can be a bit low?
Oh, that's for sure. I think if you look at the GRAIL study and many others, they'll show you that it's not impossible to detect at that level, but definitely the sensitivity and specificity decreases, and you definitely need to have a higher end technology, higher end bioinformatics, higher end chemistry reagents, and so forth to be able to detect at that level. Yes, so that's why I think you see companies like GRAIL taking 5, 10 years, 15,000 patients, 15,000 subjects to be able to prove that they can really detect at that level. Yeah.
Another interesting thought here is about the microbiome. I think it's really interesting how our gut flora can modulate the response to certain treatments. Do you think this will eventually enter, if and when it will enter routine clinical testing in the future?
For sure. I would really say this is going to happen for sure. I think I read recently that there was a report on oral microbiota affecting oral chemotherapy. So you can imagine how much of an impact that would have. And especially if it has an impact, it should be getting included into clinical practice. But as usual, it will take some time to prove it and to get it tested and to push it through regulations. But before you know it, I think it'll be there. I would say probably in 2 or 3 or 5 years, you'll be seeing some testing being performed for these for microbiomes.
Yeah, and we expect to see that in the future. Another question would be, since we are seeing a lot of companies and laboratories, both in academic medical centers and commercial establishments, offering comprehensive genomic profiling, do you advise to do it on the time of diagnosis, or do you think it would be better to wait at the time of progression where the driver mutations are a bit more varied?
There's been numerous reasons to do later and before. I get the impression that we should do it at the beginning. That would be my feeling. The reason being is by the time the testing is performed, which can be 2 up to 6 weeks or something, you may, and if you wait for a recurrence or you wait for later, you may not get the information in time. It's usually better to test as early as you can. If something happens later and at recurrence, maybe you can test again. But I would say it's quite worrying to leave it too late, because by the time you get the results back, you don't have the information to work with. So that's why I would advise testing as early as possible.
Yeah, thank you. And then I think we have a bit more time. In terms of single cell sequencing, do you think it overlooks the tumor heterogeneity when we do single cell sequencing for cancers?
Of course, but that's why it's right now very much in the research realm. We have to understand how testing single cells can impact on the whole clinical ecosystem. Like you say, tumor heterogeneity, other effects as well. It has value to be testing at single cells, but we really have to understand how that interplays with all the whole clinical ecosystem. So yes, that's why it's in research right now.
Okay. Thank you so much again, Dr. Soong.
Thank you.